Hello, this is Dr. Kotkin. Here I'm presenting the concluding part of the excerpts from SPIN 2021, Sharing Progress in Neonatology 2021, a fully virtual conference that I had the privilege of attending between the 10th to 12th of June 2021. This is the last but not the least, I would say, an important topic, say, because this is a recent concept, functional echo in NICU. This is a recent concept because you can objectively define the cardiovascular component of a respiratory distress. So the topic here is assessing the cardiovascular component respiratory pathology presented by an eminent researcher in this field of neonatology, which is Martin Klackow, is FRACP, Professor of Neonatology from Royal North Shore Hospital. Located at Royal North Shore Hospital, University of Sydney, Australia. I am Dr. Karthikeyan, consultant neonatology in Dubai. Here we're talking about excerpts of part 4 of 4-part series, Sharing Progress in Neonatology. Right, here distress in newborn is now currently termed as cardiorespiratory distress because respiratory distress has and it can have a significant underlying cardiovascular etiology that is eminently correctable, that will need action to get the baby out of the distress. So much so that it is baby's distress, tachypnea or any signs of respiratory issues is now termed as cardiorespiratory distress and not just respiratory distress. Here, Sir has come to present in a very elegant way. He presents three case scenarios, actual real life scenarios that he has seen. Case 1, 2, and 3, who have had a significant cardiovascular component contributing to the respiratory distress, and once being identified this cause, cardiovascular cause underlying the respiratory distress, it was corrected and the baby become all right, just giving the proof of pudding etiology. I said he presents very interesting case scenarios of three babies, real life case scenarios where a functional echo, a point of care ultrasound focus that was instrumental objectively identifying, quantifying the cardiovascular contributing etiology and correcting as well as assessing the response to the treatment that we gave. Clear? If you have a problem, then it should be correctable once it is identified, and the response to the treatment should be quantifiable. The same technique which identify the problem. Let's focus. It is point of care ultrasound in neonatology, bedside ultrasound, targeted, and it is functional echo. You have a few clinical questions which has to be answered objectively by the functional echocardiographer, which can be the neonatologist doubling as an echocardiographer. To obviate asking for a help that may not be available at odd hours, neonatologists or intensivists who are used to working at odd hours and have the capability to take the stress of coming at odd hours and taking out of a baby in an effective manner. Now, this first case scenario, have a look. The first case scenarios, the X-spree, 26 weeks, he was born at 26 weeks. The age 12 days means is what sir means is 1 plus, now baby's 12 days means it's 1 week plus 5 days. So it's 27 plus 5 days. Now, this is a clinical scenario. This is just 26 weeks, age 22 days means corrected age is 27 plus 5. Baby is on CPAP 8 centimeters of water and FiO2 is 45% and it's creeping up, it's going up. Requirement is going up to maintain the saturation charges of the unit. Baby had an audible PDA murmur that started detected on day 4 and it is still persisting. And the previous ultrasound, which on day 4 showed a small PDA. Here is a chest X-ray. I take pride in that. I love to see the X-rays, and I'm used to see more than 3,000 or more than the X-rays analytically. In discussion with radiologist, I can understand neonatal X-rays to a better extent than radiologists who are not that much exposed to reading neonatal X-rays. Now, having a look at the X-ray, see the soft tissue and the bone cage is a rotated film. You have some radio opaque. You can see there's an artifacts here. It's probably plaster fixation. Not sure. There's a long line inside. There's no long line. There's a clip, some sort of clips which are plasters and restrainers. Right. Yeah, we have a tube here, which is coiled. It's a feeding tube. It is the stomach, and the bony cage is how many ribs are expanded. The lungs are still patchy, and it is not homogeneous. It is mostly on the right side, especially. It's sort of fluffy and more towards the hilar and basal regions, and also upper lobe. The peripheries are relatively clear on the right side. The diaphragm is still, it's not flattened, it is convex upwards. The left side diaphragm is lower, as is expected. And the cardiovascularity is not that much distinct. You see this cardiac discount, it is not clearly distinguishable from the lung borders, means there is haziness both sides. In the left side, there is more homogeneous feature. So it's a sort of respiratory distress syndrome, which has gone to some additional issues, either pulmonary edema or infection, lung infection, I would say, or early part of coronary disease sort of things. Okay, or secretions obstructing or blocking without clearance. Now, having this X-ray, see, it's not purely respiratory now because FiO2 is creeping up. Is the maximum CPAP 8 centimeter H2O, and this is not the time where you can even consider surfactant. Literature, surfactant is better given in the first 48 hours, and the longest day of life where repeat dose repeat dose surfactants were administered with the effect was, if I'm correct, as per literature in 2015, it was day 9. Here is day 12. I don't see any reason for considering surfactant. So using the POCUS, what we got, we'll come to this later. Have this in view, we'll come to the answer later, right? We have a murmur which was small on the day 4. That much information. Next. Case number 2 is again a preterm, is extreme preterm, almost the periviable period. You have the gestation is 23 weeks, postnatal just 4 hours, and then baby is on 22 by 550 MAP. This is mechanical ventilation. Probably it's SAME, I think. 9 centimeter of water. FiO2 is 0.8. It's already very high. And mean blood pressure is 27, is acceptable, normal. There's a slight acidosis with the lactate. There's a metabolic component of acidosis with the PCO2 of 42. This is hypoxia summer. POT is 22. Maybe the early 4 hours. Now coming to the X-ray, this is see the X-rays. This X-rays, see the diaphragm is flat both sides. Means expansion is very good. In fact, I have to consider reducing the map here because diaphragm is flat, very flat, and count the number of posterior ribs. The straight portion of the ribs 1, 2, 3, 4, 5, 6, 7, 8, almost 9 ribs, which is hyper expand, almost overexpanded combined with the flattened diaphragm. Right, lung fields are essentially not that bad. They are not sudden. Cardiac celerity is very clear. There is a bit of patchiness in the right hilar region. The cardiac celerity is actually smaller, I would say. It's not underfilled heart, looks like. There's an ET tube in situ there, and there is some umbilical venous catheter here, umbilical venous line. You can see there is probably an umbilical arterial line as well. You can see this one going up. I have to define, but there is probably an umbilical arterial line as well. This is a venous line, right? So baby has all these lines and the tubes, and what's the real issue? Because blood pressure is maintained, but FiO2 is 0.8. This is black lung. So have your own guesses. I have my guess based on the X-ray itself, right? Next case is a term baby, 2 hours old. So this person makes CTG was abnormal. Elective LSES 215 by 5. This Abga score 2 and 5. They were significantly asphyxiated, intubated, probably in the delivery room, I think. And it's an SAME 22 by 5. And 50 is the rate. FAO2 is 30%, and FAO2 crept up to 100%. Just 2 hours. See, we started 30%, immediately came to 100% within 2 hours of life. Blood gas is showing acidosis, which is metabolic, without respiratory compensation. So SAME has increased 27 by 5 and 50. Blood pressure is not acceptable, 40 by 28, 33 millimeter. You can see this is practice. The baby is hypotensive, and this is chest X-ray. Chest X-ray, the lung fields are not that, but you can see a horizontal line here. You can see horizontal line, curly lines, and streaky shadows. Lungs are aerated, but there are differential aeration. Some parts are well aerated, some parts are not under aerated, and lungs, the upper part of lungs are not that expanded. The ribs are also crowded on the right side. It is not that rotated film. I can make out and feeding tube going down. Endotracheal tube. From here the tube comes, it's probably endotracheal tube. I can't see the tip of the endotracheal tube. Right. Now, how many ribs are there? 1, 2, 3, 4, 5, 6, 7, 8, 9, and 9.5. See, it's a little bit more hyperinflated. So, ventilatory part, you have done the maximum. Understand? FiO2 100%, and pressures are almost maximum pressure. See, 27 by 5. So, and baby is hypotensive. So, here's the situation. These are 3 cases. We'll come to POCUS, explain the basic things of POCUS, and then come to the answers which we derive, and the diagnosis and the treatment as well. Next slide. Go. Have a look at this slide, give you time. On our left hand side is the respiratory part. Oxygenated tissues is by the blood. And what does the blood contain? It is the content of the blood and the volume of the blood which is delivered. Both are important. The blood has hemoglobin, which carries oxygen, which diffuses into the plasma, the tissue, plasma oxygen tension, and then goes to the tissues. The pressure which is in the capillary, the arterial blood gas, capillary blood gas determines the diffusion to the tissues. So hemoglobin level is important, and the flow of the blood perfusion is important. You see the cardiac output. Cardiac output on the left side as well as the right side. So it's important. Heart has a crucial function. It has to from the waste blood to the right side to get it oxygenated and then circulated by the left side function. So rate, rhythm, stroke volume, all important. The traditional terms, preload. Both right and left ventricle, they have a preload and afterload against which they contract. Preload is the load which is the fluid or the volume which distends the ventricle. That has to be adequate because Stokes law. It's the heart is functioning. Once it distended, it will contract. Stokes law. So that is important. Preload is also important, not to the extent of overfilling, underfilling, adequate filling. Afterload is a pressure against which the resistance against which the ventricles pumps. For the right side, it is the pulmonary hypertension. On the left side, it is the arterial resistance of the arterial side. So the pulmonary vascular resistance is increased. Resistance into leads to the multiplication of blood pressure. So pressure on the right side, on the left side, resistance, the load in the left side, right side is increased. Then afterload will be increased. So and then contractility, the power of the heart. There's a balance of which balance contraction should balance by the preload and afterload. So these three are the which affecting the stroke volume. and the rate and rhythm are also important to achieve a cardiac output. Cardiac output equal to stroke volume into heart rate. Now, so that delivers the oxygen to the tissue. Both are important. Content blood is determined by the oxygenation status in the lungs. Alveolar capillary gas exchange. As gas has to go, carbon dioxide has to be eliminated, oxygen has to get in, and that is pumped by the heart. Heart also pumps to the lungs. As it's not that the heart doesn't only pumps to the left side, it pumps to the pulmonary arteries, which is equally same volume of blood as it pumps to the left side. Now, listen properly. This is a physiology called lung part, cardiac part, and the interaction is very important to effectively ensure adequate oxygen delivery to the tissues and delivery of blood to the lungs as well, both in the cardiac output. So relationship between the heart and lung, initial transition events or deferred cord clamping and effects of positive pressure ventilation. Deferred cord clamping will increase blood volume available for the baby, and in many instances uh, it obviates the need for a few transitions with associated risk. Many other beneficial effects have been found because of our deferred cord clamping. How to achieve this for high-risk deliveries is content of research. Effects of positive pressure ventilation on the preload or versus mean airway pressure, impaired venous return and direct compression also heart also is compressible. So sort of very high pressures can cause a tamponade effect on heart itself. And RV performance and ventricular interdependence. So these are all important. Ventricles, right side, left side, and right ventricular performance all are important. This all can be assessed by echocardiography. So the physiology of the transition is high mean airway pressure will be reducing the RV preload because venous return to the it is a venous return to superior vena cava, inferior vena cava. When there is high mean airway pressure, there is increased intrathoracic pressure. So against which the systemic venous return will be lower. So RV preload, ventricular preload will be reduced. So high mean airway pressure is to RV preload reduced. High pulmonary vascular resistance will decrease the left ventricular preload. Look here, high pulmonary vascular resistance also comes here. Here it decreases the LV preload because the pulmonary venous return to the left atrium and then to the left ventricle will be reduced. And high pulmonary vascular resistance is the resistance against which the RV has to pump. So RV afterload is increased. So RV afterload increase and RV strain also leads to LV underfilling and LV underfunction or dysfunction. So this is interdependence of the ventricular functions. Everything is in interplay, right? And here we have this high pulmonary vascular resistance, which decreases the RV contractility. Against the resistance, it has to press with hard efforts. Acidosis secondary to pulmonary hypercapnia will decrease the contractility as a whole, not right or left. As a whole, the contractility is reduced. Afterload of the is affected by high pulmonary vascular resistance and positive intrathoracic pressure with positive pressure ventilation or the MAP will decrease the LV afterload because pulmonary venous compression. Is that clear? So these are the interplays of the ventilatory adjustments on the cardiac functions. Contractility, preload, afterload. What factors affect in which way? Should be this chart should be remembered. I'll give some time for study this chart. Please have a look. That's next slide. So physiology in transition, spontaneous breathing and positive pressure ventilation. In spontaneous breathing, intrathoracic pressure decreases. A clear concept here. And so ventilation is not a physiology. It is we are imposing. So positive pressure ventilation is not physiological because intrathoracic pressure increases. Airway pressure increases. See here. So this is positive pressure ventilation by intubation is not physiological. The whole concept of non-invasive ventilation came because this is not physiological. Non-invasive support is a more physiological way of supporting the baby's breathing. Understand this concept very clear. Intrathoracic pressure, depending on lung compliance, spontaneous breathing is variable, and then here the transthoracic pressure means pulmonary and the pleural pressure. This difference. Pulmonary pressure is the ventilated pressure which passes across the time constant, and the pressure of the ventilator settings high pressure. The pleural pressure is normally deciphered by a esophageal balloon. So in spontaneous breathing, transthoracic pressure is very variable in the phase of respiration. Here it is dependent on the lung compliance. So the intrathoracic lung pressure has to be very high. In spite of that, it will not be reflected in the transthoracic pressure. If it is very high, then it may lead to blow up to pneumothorax. Then venous return is increased in spontaneous. When you take spontaneous breath, what happens? Intrathoracic pressure decreases. So venous return will be increasing, but in push air into it, the venous return will be impaired. And the stroke volume also during spontaneous respiration is relaxation. During relaxation, what happens? Venous return is increased, stroke volume also increased. But positive pressure is not. The invasive ventilation by ventilators is not physiological. It reduces the venous return. It also reduces the stroke volume. Have this concept clear? Why we are favoring non-invasive ventilation as the current more physiological way of supporting the baby's breathing. Next slide. So now we come to the assessing cardiorespiratory interactions. The point of care ultrasound, which is short named as POCUS, P-O-C-U-S, point of care ultrasound, as applied in NICU. A neonatologist should be able to develop, as I said so, because we are the intensivists, we are tuned to work at odd hours effectively. So we will take the stress of taking care of a sick baby. What we assess in the point of care ultrasound as relevant to the cardiorespiratory interactions, it has to be focused. It's not that we have a target. We need to know what we are going to see. It's bedside. It is real time. It is focused. It is bedside. It is real time. It is we need serial, not only one. And function. It assesses a function only. It's function of the heart. As a heart, does it pump adequately, and what are the impairments to the pumping action of the heart, and understand the physiology, why is it so, and define objectively what is causing the problem, and then refine the clinical decision. We have a few drugs, see, PDA closer, cardiac inotropes, milrinone, pulmonary vasodilators, nitric oxide. So, and then target treatment and monitor responses. Here the loop is closed here, the green, the loop is closed. Shorter focus, bedside, real time, serial, function mainly, understand the physiology, refine clinical decisions, target the treatment, and then monitor the responses. This is the complete circle or the loop that will make you understand what you mean by the point of care ultrasound in the evaluation of a baby with cardiorespiratory distress, the interactions of the cardiac and the respiratory components of a baby with respiratory distress. I'll give 5 seconds for you to study this slide. The importance of filling and preload. So therapy has to be tailored to the need. Suppose assessment of filling, suppose you give fluids. The fluid, giving just a simple thing as saline bolus is a therapy. It fills the heart because stroke volume of the heart stroke equation, stroke saddle. It or stroke equation. It the cardiac as chamber has to fill is a smooth muscle. It has to. It's not a straight muscle. It's smooth muscle. It has to fill so that the capacity is. So it can contract also. So at an optimal, the contracting function is optimal at a particular distance of a sphere. This is the law. So inadequate positional therapy is not good, and over therapy also not good. Overfilling also will make it tired. So optimal provision, increasing therapy provision. Understand this clearly, and there will be increasing complications either with inadequate positional therapy or over therapy. The graph, look at it clearly. I'll give you 3 seconds. The curve is a parabolic curve. The ideal point is here. Now Doppler cardiac output, that was the preload. Now this is the real function of the heart, cardiac output against the afterload or resistance, right? This is the, if someone is clear, it's the parasternal lung axis slightly modified. Measure the diameter and calculate a cross-section area pi into diameter square by 4. Pi r square, cross-section area. Pi r square, radius to the square is diameter by 2 whole square, diameter square divided by 4. Understand? Simple maths. Pi r square. Pi r square is the cross-sectional area of your sphere, which in cut is a circle. Obtain the velocity time complex, that is time interval, velocity time interval, here is here, velocity time interval by pulse wave Doppler and measure the integral. You have to graph like this and measure the velocity time interval. This is the velocity. The velocity varies over this period. This is the time, this is the velocity. So measure with a graph what is the velocity time interval and multiply it by the pi r square. We get a stroke volume. These are echocardiography calculations for mathematics. Cardiac output equal to stroke volume into heart rate, and cardiac index is cardiac output divided by birth weight. Clear? So this is basically the left heart function. This cardiac output. What do you mean by cardiac output is normally left heart function. The one which pushes blood to the tissues and the vital organs, including brain, kidneys, and other somatic organs. Look at these equations for 5 seconds. The formulas. Right, cardiac output can be measured for both hearts. So, right, we need to get the velocity time interval for the right side, which is across the pulmonary blood, and then velocity time interval across the LV output is across the aorta. So, this same pattern you get. This is short, arterial output is very short, spike and then down. So, we have we have this and we can calculate the LV and the RV output as well. Both are equal here. See, normal 200 to 300. It is normal, but here the difference is that RV output is 147, LV output is low. Correct? You have the difference. All right. We go next slide. So, effects of the cardiovascular system on the respiratory system, cardiorespiratory interactions, patent ductus arteriosus, it is increased pulmonary blood flow, decreased pulmonary compliance, and the leakage. Leakage is the pulmonary edema. What do you mean pulmonary edema? Patent ductus arteriosus steals the blood from the systemic circulation, from the aorta in the normal situation. And the pressures are the same as aortic pressure here. It steals the blood from the systemic circulation and floods the pulmonary circulation. And because of the edema, decreased lung compliance and leakage also happens. Pulmonary hypertension will lead to increased due to increased pulmonary resistance, pulmonary blood flow changes, and it will reverse the, it can reverse shunts. Any left to right shunt become right to left. A longer term, it will lead to CLD and PPHN current. I said you in one of the earlier presentations that current thing is the angiocrine factors. A vessel wall and the early pulmonary hypertension leads to persistent pulmonary hypertension later on and also increased risk of CLD. This was the keynote lecture, Brent Memory lecture, if you remember. That was the earlier presentation. So be clear, cardiac evaluation is an important part of assessment of any baby with respiratory distress. A PPROM less than 20 weeks of gestation, what we should do, that also will be more clear by the cardiovascular assessment by focus. Asphyxia will lead to reduced cardiac output and venous congestion. In fact, cardiac dilatation can happen. Cardiac contractility also is reduced, and then you can be able to identify a congenital heart disease. But clear delimitation and accurate assessment of a congenital heart disease is in the hands of certified pediatric echocardiographers who have adequate training in neonatal echocardiography. Okay, so this you will refer to the pediatric cardiologist, but rest of all the focused functional echocardiography, a neonatologist should have the skill. That is an asset. That's a slide. Right, the patient Ductus Arteriosus already told now. It steals the blood, pulmonary blood flow increase, pulmonary capillary pressure, shear stress, left heart, lower, right hand, left, both are affected by the patent Ductus Arteriosus. See, it steals, increase pulmonary, it steals, systemic blood flow, it is a steal from the systemic to the pulmonary side. Decrease perfusion, simple term, it's a steal from the systemic circulation to the pulmonary circulation. Study this slide, I get to 5 seconds for it. You raise that PDA if it is significant. So HSPDA should be closed, or you attempt to close pharmacologically or sometimes by surgical means. That is hemodynamically significant PDA or HSPDA. Here is we find in patent Ductus Arteriosus. This is echocardiography view. This is short axis or modified short axis view of you can see this tricuspid. This is Mercedes-Benz appearance of the aortic wall, tricuspid wall, and this is a pulmonary artery which is arching across main pulmonary artery, right angle outward main pulmonary artery dividing into RPA and left pulmonary artery. Here with the duct, arch of vital left circumambulatory artery is a duct. The steel will be through this here. And here the point of assessment, and here also yes, a descending aorta will be the flow here. There might be reverse flow in the descending aorta. Be clear, reverse flow. You can see it's away from the probe. This is forward flow. You can see some flow on the antegrade side. This is reversal, and here this is more towards the pulmonary side. There is a milder left right component also. That is which is towards this probe is here. Probe is lies towards away from the probe, and then this actual flow. It's a bit laminar. It's not more violent, but this is the flow. So these are patterns of patent Ductus Arteriosus flow assessment of PDA. This is the velocity here 200 this velocity full graph is not is the velocity is being measured. This is PDA. Same is a minute. This is graphs here. Next, this now coming to the case number 1. I do remember the case number 1 that was an identical with 12 days. You need 26 weeker, 12 days. I said 21 plus 5 who had creeping up FiO2 and already on maximum pressure. We cannot do anything with the respiratory part. What we see, and there is a PDA, small PDA, which was diagnosed on day 4. So we do another point of care ultrasound. PDA diameter is 3 millimeter here. This is the PDA diameter, and there is a reverse flow. See, I told you, this descending rate of flow should be away from it, but here there is a forward flow. There is a reverse flow in diastole. This is systole and that's diastole. Both SMA as well as there is a reverse flow in the diastole, which means there is significant still. That is hemodynamically significant PDA. So I think of that. These are the hemodynamic assessment. LAAO 1.4 up to 1.4 is acceptable. 1.9 is definitely abnormal. Left atrium is distended because of stealing pulmonary blood. More amount of pulmonary blood is returned to the left atrium. Pulmonary diameter is big because through that only steal is happening. And reverse flow in diastole means systemic affection is already there. So pulmonary side is affected, systemic side is affected, and there is a huge size of the duct. So this is a classical Here I saw this is the ductum. So here this is a steel which is significant, hemodynamically significant. This is a turbulent high velocity jet. This is something across the duct. This has to be closed. Now this is number one. Here. So here we had the in another case I was telling you, audible PDA memorization report. We have the PDA diameter pulsatile flow 2.5 meter. Any flow more than 2 meter per second is abnormal in newborn. Here, flow up to 2 meter per second can be physiological in some instances in newborn. So here we have all these values. It's a large human and significant PDA. So treat with ibuprofen as per the unit policy in Sydney. Postnatal age at treatment was 12 days and PDA reduced in size following the ibuprofen course. Improved oxygenation and CPAP in PDA closed 2 to 3 weeks later. Ibuprofen course for 3 to 5 days. So we're able to get off the support, you understand? CPAP as well, that is the main thing. And then PDA, once the support is weaned and further adjustments, so PDA close to the exit. So we achieved a reduction in closure. I am sure they would have found that there is a dramatic reduction in the hemodynamic significant. The parameters would have been better. So pediatric assessment of PDA closure, documentation by POCUS, assessment of response. We told, remember that loop has to be closed. PDA closed 2 to 3 weeks later. Check some time for complete closure of PDA. You should never reopen. That's also important. I will come to in different presentation. Reopening of PDA, how dangerous it is. So pattern of ductus exposure in PDA, length of exposure shunt is very important. Baby intubated 10 days, no difference in PDA in BPD from shunt exposure. But a baby who is intubated for more than 10 days, there is an incremental increase in BPD rate with a longer shunt exposure. Understand? The current analysis says in 2020. So though you have to get rid of a PDA angle in babies who are going to be requiring support. Where it mentions only intubated, it equally applies to a baby with a non-invasive support. You, as per the first case, baby was only on CPAP, but that also might be dangerous when you see more smaller babies. All the support invasive, definitely no. Non-invasive, yes, to the extent it can be minimized, it can be given, but this is a comorbidity, hemodynamic in the PDA, which has to be closed effectively without an additional complication that may result from the treatment or from the PDA itself. Study the slide first, 3 seconds. Next, this is the PDA tolerate trial published in 2020. So here an infection along with the PDA, a wet lung is prone for infection, clear? A wet lung is prone for infection, bugs will multiply that, and so the risk of development is more increased if there is PDA in infection. Infection per se is a independent respector, ureaplasma or other organisms. Or on the top of it is a PDA, put together, it's tilts angle. See the risk of CL, how much it is. It's a geometric progression. It's not ordinary progression, it's geometric progression. PDA, see the risk of CLD 10-fold, more than 15-fold. From 10-fold to 15-fold. Understand? This is geometric progression. So clear, PDA and infection together are major villains. PDA associated with temporary sepsis also. This will be very clear. This is from earlier studies, 1996, Ben Clory, an authority on bronchopulmonary dysplasia. So next is PPHN is assessed by POCUS. The respiratory effects of pulmonary resistance, systemic blood pressure, pulmonary pressures, suprasystemic pulmonary pressure, suprasystemic. The pulmonary pressure overrides the systemic pressure. That's reversal, left, right. So right, left is okay to a certain extent. Hemodynamic that also need to be closed, but left, right is dangerous because it is a no therapy, nitric oxide therapy at that time. Right. Impaired cardiac function and filling is asphyxia. PDA open or closed. These are the answers we get. Right ventricular function impingement, left ventricular impairment. Combination of these elements will define the clinical presentation and the treatment equations. The equations of all this put together. Clear? So we need to have pulmonary vascular resistance, systemic blood pressure as calculated by echo. Pulmonary pressure is suprasystemic or subsystemic. Impaired cardiac function or filling, this is preload. Right? Be clear, preload. So preload, afterload, contractility and the resistance and the output. Simple mathematics and the equations of POCUS. So interrelations between right and left parts of the heart. Study this graph for 5 seconds. I leave for some time. This was tabulated before, as I told. No, pulmonary resistance is will be affecting the RV outflow. It is a load on the RV after load, but it is a LV preload. So after load for the right is increased, so the and this are cycles, so everything will be impaired. So the LV dysfunction or increased so systemic hypoperfusion and shock can result from PVR. So transitional circulation ultrasound assessment is process, pulmonary vascular pressure. This is what we see in POCUS. So just clear, it's preload, afterload, contractility and the resistance and the output, systolic, diastolic, air function, function both sides, shunts and the flows, the velocities is known, and the output is calculated velocity time interval, VTI and the pi square area. This much blood is calculated flow across the area. So it is VTI. Velocity time interval by pi square is the volume. Pressure. So coming to the second case, extreme preterm remember 23-week, few hours old. We have must have black lung. It was a black lung. Understand? It was a little bit block lung, and we are assessing here. There was a raised pulmonary artery pressure, and the PDA was pure right to left shunt. Left right or right to left. This is right to left, which is suprasystemic pressure. And the PDA diameter is also 2.5. Here the villain is PDA is shunting, is not close this PDA. Understand? Ah, so we have this calculation. The meter per second more than 2. In this instead of if people don't know color wave Doppler CW is better than PW in assessing high flows accurately. For those who know echoes, pulse wave, color wave. More than 2, I think. We're going to put CW. Right. Right. We now go. This is the assessment angle, and velocity is 324 centimeter. Assess gradient 42 millimeter in 23 week. The pressure is 42 millimeter. The pulmonary and the systemic pressure was already displayed. You can have that. Next slide. Here that. 42 we had the see 40 plus 4 the RV pressure 42 plus 5 for the 47 millimeter of mercury. We have the systemic pressure 27. So it is suprasystemic pressure reversal all the directions. Systemic also overrun by the pulmonary circulation. Diastolic so both ways. System is a pure right to left side means it's suprasystemic pulmonary. Let's say PF bidirectional shunt, PDA pure right to left shunt, raised pulmonary pressure, normal myocardial function of the output. So this is lactate, acidosis, everything is contributed by the increased pulmonary resistance. I also said this is a black lung, that is PPHN. Already we are in the maximum ventilation. I remember that X-ray. Yeah. So now, based on X-ray itself, it is a PPHN because we are to the hypoxia test is failed. Oxygen might be able to increase the rate to say hypercap as you have cardiovascular to say PPHN. Yeah, that whole time, hyperoxia, hyperventilation test, pure congenital heart disease, PPHN or non-cardiac, only respiratory. You go and read about that, how people had been thinking about getting an objective assessment of the contributions of the lung and the heart in the distress of a baby. So, right, it's pure right left shunt. Treatment is not closure of PDA, my dear. It's 2.5 minute PDA. The quack will just close the PDA. The baby will collapse and die. You have to commence no. Inhale nitric oxide at 10 parts per million at 5 hours of hold. Rapid improvement oxygenation. So he started 10 p.m. It's see preterms receiving nitric oxide should be by a consultant decision. Nitric oxide as it stands sits for 35 weeks and above on term babies. Preterm baby, especially those at 23 weeks, it has to be very much by a consultant or a team of consultant decision. Rapid improvement oxygenation and wean to below 50%. The pressure is also weaned off. Correct. Now the blood pressure is stable now. Hopefully there would have been a serial echocardiogram which is demonstrating fall in the pulmonary hypertension. So this much pressure is enough for a 23 weeker, main or a pressure 25 millimeter. Okay. So the PPHN management principles are there is a vascular component, there is a parenchymal component. The parenchymal component is the lung component, the surfactant. In this previous presentation, I said surfactant. Early surfactant coupled with INO might be the best treatment to achieve and prevent CLD. Current concepts. So now, no, for high pulmonary vascular resistance, early pulmonary hypertension has to be attacked as vigorously as is in any baby, irrespective of the gestation. So here, see, here if you ask if the pulmonary hypertension will go on progressing like this. So when you attack this one, it will fall in tandem over the time. So severity of hypoxia, otherwise to the vascular component will keep on creeping up. See, if we leave this undertreated, this graph will be, they will be oxygen dependent. Parenchymal component, we have surfactant and ventilation, it will come down. But this, if not treated appropriately at an earlier point of time, they will remain hypoxic. That's what happened at an early hours of life in that small baby who had good, okay lung expansion block, but there was a vascular component which has to be quantified and titrated. Therapy has to be given. No, inhale nitric oxide. By high pulmonary vascular resistance for a small preterm. I said it's a considered decision for extending nitric oxide for such a preterm baby. Study this slide again. So PPHN contributors cardiovascular function, pulmonary artery pressure, lung function, and the lung distension. LV dysfunction, pulmonary artery pressure, systemic artery pressure. This is a ratio because the shunt is there, no? PDA. So the shunt flow is determined by the pressure equations on both sides, pulmonary and systemic. LV dysfunction also affects because LV is not pumped, there is a flooding backlog which will increase the flooding of the lungs. Mechanical ventilation, I already told, is not physiological. Invasive ventilation is never physiological. Over under distension effect on PVR. Hypoxic and acidotic pulmonary vasoconstriction, direct effect of treatments. These are all contributing factors. A clinician should weigh all these factors and initiate and titrate the responses. To this, so deconstructing hypoxia components. What is the factor that's causing the hypoxia? Is it a lung vascular component? Is it a lung parenchymal component? Or is it a cardiovascular component? So there are armamentarium of drugs to attack all this cardiovascular. We have inotropes, drugs to close shunt, lung parenchymal surfactant, and non-invasive ventilation, minimally surfactant therapy, gentler way of surfactant, and gentler way of support. Lung vascular is no nitric oxide, inhale nitric oxide. Nanotechnology is also coming in here, might be in that, might be in here also. Clear? Three components: lung vascular, lung parenchymal, cardiovascular. Conceptually be clear. When you see a hypoxic baby, hypoxic respiratory failure, this way you should understand, assess, quantify, initiate treatment, and follow up with objective assessment and titrate the response and the treatment. So number 3, the baby, remember that is a term baby with this pure right to left ductal shunt, low RV output. This is this term baby, little bit of asphyxia. The ABGAS score 2 and 5. and lactic acidosis as metabolic acidosis. BP had a pulmonary artery pressure 38 millimeter and pure right left shunt. Again, it's pulmonary hypertension at an age of early age. Right ventricle output, you can see right ventricle output ml per minute, many calculations are there. So just come. So we have a cardiac function, low cardiac output, low RV output, LV output, McEwen graph. There's output and there's hypertension, both are there. Understand? There's an output, low output, so you have to give some pumping contractility booster, drops. There's a right to left side, no, nitric oxide. Clear? So this is the baby. CT jump number. There is an asphyxia. Baby is intubated. 100% oxygen. SpO2 86. SAME maximum. Pressure is not. See, systemic pressure. When the blood pressure is not there, LV function is impaired. So that much is very clear. We can't measure the pulmonary pressure. It has to be quantified by the echo. Understand? So pulmonary arterial pressure has to be quantified by the echo. It cannot be measured clinically. But your blood pressure, if it is can be obtained non-invasively or by invasively, this is a good surrogate marker for the systemic perfusion in many cases. But it will be coupled with the capillary refill time. That will come in a different presentation. So RV output is decreased, poor RV function. There's an open PDA. Estimated pulmonary pressure almost 40 millimeter mercury systemic pressure. It's almost equal to systemic pressure. That was the finding in the term baby. So I already told you cardiac function is less and it's a no for this pulmonary pressure. So what is the inner drop plus? So take the dobutamine 20 mics since it's a term baby, inhalating 20 parts per million, the maximum per meter. Dobutamine 10 mics and the inhalating also. So in the preterm baby, you start 10 parts per million. Some people may start at 5 or 3 also for preterm babies. Here's a term baby, so inhalating also 20 parts per million. Rapid improvement in oxygenation ventilator pressures being dropped. So it's the more quicker. Intensive care is intensive care. You have to get our support very fast. The quicker is better, faster is better. So thank you for your attention, Sir said. I also say thank you for your attention. This is a very interesting topic because this is a topic I have a personal interest. I have the European Association of CardioVascular Imaging certification in scanning small babies. So it's an interesting topic to me. Thank you for your attention. It's an interesting topic. The cardiovascular component of a baby who is distressed. It plays a very significant part, and the more smaller you become or the severe problems in a term baby, both have an underlying serious cardiovascular component that has to be identified, quantified, treated and monitored for the response to the treatment. With these words, we close this final part of excerpts from SPIN, sharing progress in neonatology. This is me, Dr. Karthikeyan, consultant neonatology in Dubai. This is the concluding part of excerpt of SPIN 2021, a fully virtual update on neonatology from the world top researchers and leaders. Thank you.